Assalamu alaikum. Welcome to today's Cataract Surgery Insight into yet another Morgagnian cataract. I am Dr. Abdurrahman Muhammad Alam. This patient is suffering from a Morgagnian cataract. I've decided to take up this challenging case. I'm making two side ports with a 15-degree knife in right side and left side. Now I'm staining the anterior capsule with Trifan blue. While the anterior capsule is being stained with Trifon blue, I'm creating the cystitome. Now I'm washing out the Trifon blue with PSS. Now I'm refilling the anterior chamber with OVD to form the AC. Now I'm creating the main port with a 2.4 mm keratome. Again, refill the anterior chamber and commence with the creation of the capsular rhexis. Incise the anterior capsule and raise up a flap, which caused a spontaneous decompression of the intercapsular content while the liquefied lens cortex came out, reducing the intracapsular pressure. Now, with the help of a rhexis holding forceps, guide the flap to create a continuous curvilinear capsular rhexis. Always refill the anterior chamber with OV2 and commence with the creation of the rhexis. When liquefied cortex comes out, inject OVD to displace the liquefied cortex from above the rhexis flap for better visualization. Now perform little bit of washing out of the liquefied cortex with injecting PSS. Now dial the nucleus and see how it is mobile. Now with the phaco handpiece, groove out the central pit. The second instrument, stabilize the nucleus in order that it does not spin while sculpting a central groove. When you have reached a sufficient depth, perform direct vertical chop. Continue with the chopping maneuver and perform multiple chop pieces inside the PC bag. Continue chopping of all the pieces in the PC bag. Last piece is difficult to chop, so I decided to lift it up into the anterior chamber and emulsify the chopped piece in quadrant mode. Reinject OVD to protect the endothelium and commence with the emulsification of the chopped pieces. One, two, three, four. Four pieces are attached to each other at the posterior plate. Slowly lift up the piece and emulsify the attached portion, and you'll have three pieces. Now all the pieces are separated. Now emulsify the chopped pieces while introducing a spatula to protect the posterior capsule from PCT. All the nuclear pieces has been successfully emulsified. Now remove the residual cortex with bimanual irrigation IA handpiece. There is little bit of cortex because all the cortex has liquefied in this Morgagnian cataract. So I'm performing polish of this posterior capsule. There are some areas of fibrosis which are not which I am not able to polish and remove. because of the fibrosis. Now enlarge the main port incision to 2.8 mm with a keratoome. This will help you in easy IOL implantation. Now commence with IOL loading into the IOL cartridge. Now implant the foldable IOL into the PC bag. With the spatula, slowly guide the tailing haptic into the PC bag. Now only remaining part is the removal of the injected OVD. The nucleus and remove the OVD that is trapped behind the IOL optic. I noticed that there was a bit of residual cortex on the right hand side, so I have taken, so I'm trying to remove that cortex with the aspiration handpiece. Perform stromal hydration of the side port and main port. In this case, the vitreous pressure is very high and the AC is trying to collapse. So I'm re-inflating the anterior chamber with PSS and performing adequate stromal hydration. Now, relative the AC is formed, inject intracameral antibiotic followed by injection of subconjunctival dexamethasone. Thank you, my dear friend. Hope this surgical video was helpful in developing your surgical skills.